Welcome. Good morning. Great. Thanks, Winston. Good morning, everyone. This is our next installment of our orthopedic visiting professor lecture series. This is done in collaboration, in conjunction with our plastic surgery colleagues. So welcome to our plastic surgery team. This is the Morgan-McCue visiting professor in hand and upper extremity surgery. I think this is the 12th or 13th year we've had this conference and this lectureship. It was started in honor of Dr. Ray Morgan, who's here with us this morning, and Frank McCue, my mentor here in orthopedics. They started our hand fellowship program in 1991, and we added to and started the second hand fellowship in 2010. Dr. Morgan was chair of plastic surgery for 29 years. He helped Thomas Jefferson build the rotunda, and he knows this town inside out. You guys laugh, he knows everything about this town. You think I know a lot about this town? He makes me look like I'm in kindergarten. But Dr. Morgan has was one of the main reasons that orthopedics and plastics hand surgery came together. So I'm forever grateful for that. Dr. Hollenbeck, the chair of plastic surgery, is here as well for this morning's lecture. So thank you all for being here, and it's always a great time of year for the plastics and orthopedic hand divisions. I'm really honored to present one of my best friends for many, many years, Dr. Tamara Rozenthal from Beth Israel Deaconess Medical Center. She's a professor of orthopedic surgery at Harvard Medical School. She has received her MD from Cornell Medical School, did her orthopedic residency at University of Pennsylvania, and did her hand and upper extremity fellowship at Brigham and Women's Hospital. She treats a wide variety of problems, including trauma and degenerative conditions of the hand, wrist, and elbow. In addition to her clinical work, she's a very active researcher and has numerous publications in bone health, fragility fractures, and outcomes in hand surgery. She's a leader in orthopedic and hand surgery education, and currently is the president of the American Society for Surgery of the Hand. So I've worked with Tamara for the last 6 years on the Hand Society Council. Her upcoming meeting is in Vancouver in October, and I have the position of following her as president, which will be a very hard job to do because she's already elevated what we're doing as a society in a tremendous fashion that anyone who knows about ASSH and hand surgery know what Dr. Rosenthal has accomplished already in her time in the presidential line. So I'm very grateful for her taking time from her busy practice and her family to visit us today, and welcome.
Well, thanks for having me. I mean, the honor is mine. It's really great to be here. I'm too short for this. Can't follow that to Chava. It just never works out well for me. So again, it's really fantastic to be here. I'm super excited. And what I was hoping to do this morning to start off was just give you a little bit of the tour of what my research journey has been in this topic of bone fragility, which is kind of probably a little bit of a strange one for a clinical surgeon to be working on. But hopefully when I'm done, you'll kind of understand how I got into it, and hopefully we have a good discussion about it. So I think I began to get interested in this when I was a PGY1 and PGY2 residents at University of Pennsylvania, just because of the amount of fractures that we were seeing in the emergency department. So as all of you know, from distal-radius fractures, it's like the most common upper extremity fracture. It accounts for about 2% of all the ED visits that we see. And there's lots of risk factors that we really can't modify, like age and sex and the season of year. And then there's a few that you can perhaps modify. But at the time when I started to get interested in this, it was really because we spent a lot of time talking about hip fractures and what their effect on morbidity and mortality was. But the effect of wrist fractures was really not very clear. So my very first research project as a PGY2 was to take a cohort of patients from, again, Philadelphia at the time, and it was about 300 of them, and to try and look at what their survival did over a 7-year period. And then we matched them to a population without fractures in that area. And what we ended up looking at is just what their survival was. And what we found at the end of it is that the patients who had a fracture actually had a decrease in survival over that time period. That was, 57% versus 71 in the non-fracture group. And the survival among men was worse than among women. And as you would expect, if the patients had comorbidities or other issues, their survival was decreased as well. And so that kind of brought the first question of, well, why is a distal radius fracture a problem? Is it the fracture itself that causes an issue, like a hip fracture, or is it just a marker of something, of bad things that are gonna happen later? And so that was what got me started into this topic of trying to answer that question. One of the potential reasons why a distal radius fracture could be a problem is because we know that many of these patients have underlying problems in their bone health of osteoporosis. And there's ample data, both in the rheumatology literature and in the orthopedic literature, that we don't do a particularly good job in screening these patients and in managing that. So approximately 1/3 of patients will get some type of screening after a fracture. And that's been well established over a long period of time. So at this point, I've graduated residency and fellowship. I have my first job as an attending. I'm in the Harvard system. I'm told that in the Harvard system, everything's perfect. It's the Mecca. Nothing is ever wrong. So I was kind of interested in looking at what the experience was there. So first year as an attending, say, all right, well, let's replicate this. Let's take a cohort of patients who've been treated for distal radius, and let's see what we're doing now, 10 years later. And looking retrospectively, specifically just at two things, how many people got screened after a fracture and how many people got treated. What we found was that, in fact, we were no better than the literature that was a decade older. So after a wrist fracture, only about 20% of patients actually had their bone density done. If they did get one, almost all of them were abnormal. 1/3 had osteoporosis, almost 2/3 had osteopenia. What was interesting that is if you did have a bone density, your likelihood of treatment was a lot better, but the majority of people, like over 70%, got nothing, like not calcium, not vitamin D, just nothing. So completely lack of a follow-up. So we designed this really kind of silly process to kind of figure out if we could make it any better, because there's lots of literature that's looked at how to bridge that gap. And some of it's, do we send emails to patients? Do we spend time educating our patients? When patients are inpatient, we have them captive. Can we have some education that occurs at that point? And then the more sophisticated cases, and I'll talk a little bit about this later, is fracture liaison services, where you rely on a multidisciplinary team to do this for you. The more effective these things are, the more expensive they are. So we just wanted to try something simple. And so the idea here was, okay, well, let's randomize people who come to the ortho clinic. We're either going to send a letter to the PCPs and say, please do this, or we're just going to do it ourselves and order a bone density test. And if you look at the table and the little box in red, what was interesting is that if we actually took ownership of it and ordered the bone density, over 90% of patients actually went ahead and got it. And almost 90% had a discussion about treatment that was documented somewhere in their chart. Whereas if we rely on the primary care doctors to do it and just send them a letter, we're kind of stuck in that 30%, which is where the literature has been for a long period of time. So from there, I kind of got interested in the topic of what do we do with men? Most of the research and the screening has always focused on women. But the estimate of what fragility fractures are going to be doing over the next few years is that they're going to increase at least threefold in men. And we don't really understand how you treat that population. Like, should we treat them the same? Should we do the same drugs? Should the same screening criteria apply? So we went into looking at characterizing it a little bit better and to looking at how we do in screening men versus screening women. And so in a cohort of men, again, in our practice, we found that if you were a man who had a distal radius fracture, you were about 10 times less likely to actually get a bone density test. And you were almost 16 times less likely to get treatment if your results warranted treatment. And so you might think, well, maybe it's because men are just not as high risk. Maybe they don't need to be treated. But if you use the FRAX algorithm, and I don't know how many of you are familiar with it, but it's basically an online calculator where you plug in some basic factors like age and sex and history of a fracture, and you put in bone density if you have it, and it gives you what the estimate of a fracture in the next 10 years is. So if you use the FRAX algorithm, a lot of the men were actually high risk. So it's not that we shouldn't be screening them or treating it, it's just that we're completely ignoring it and just not doing it. So the screening obviously lags behind. And the guidelines are actually there. So the CPG guidelines say that men should be screened if you have a fragility fracture after the age of 50. I think we're just completely ignoring it. And I always laugh about this because I've done research on this topic for a long period of time, and like the one study I publish on men gets like all the press. So clearly I need to focus on this more in order to get the appropriate attention. So from there, kind of decided to take a little bit more of a qualitative research approach. And this is a more new topic for me. It's not something that I had a lot of experience in. And so trying to identify what are these critical care gaps in the male population, and why is it that they're getting completely ignored? So we recruited about 22 primary care docs in our health system and did these long interviews and trying to define what the barriers to care were and what the differences in the workflow are between how they manage women and how they manage men. So I'm going to share that with you today. It's a little sad, but this is our group of PCPs. So mostly just to show that it was it was a pretty varied group. We had some young, some old, and some treated, more women and more men. And they were nothing particularly specific about the group that we selected. Just to want to preface by saying that obviously this is just in one health system in one region. So we're talking about, Metro Boston, New England, and you can't generalize that to the rest of the country. But I think it does give you a little window because, in northern New England where we don't see a lot of sunlight, like if we're not treating osteoporosis right, we kind of have a problem. So this is what we found out, is that all of our primary care, the group that we interviewed, they all say they screen women, but most say they don't screen men unless there's a reason or an underlying medical problem. They tell us that there's no guidelines for screening in men, and very few are actually aware that the guidelines exist. They have electronic reminders built into the medical record system for women for screening, but they don't have them for men. Whenever they were talking about osteoporosis, they would refer to their patients as female or she. And very few actually reported any experience treating men with this disease. And they reported a lack of quality metrics, and they don't think that they're being paid or reimbursed to treat this patient population. They don't think they have enough financial incentive to do so. In terms of the diagnosis, they said that they really only work up osteoporosis in men if there's an incidental finding or a fracture. And so they're really relying on the radiologist making a comment on the X-ray report or a surgeon to bring it up, which is kind of interesting. And they're not really familiar with what the definition of a fragility fracture is. They don't know what that means. They say that they're equally comfortable in diagnosing it in men and in women, but in men, they think it's a diagnosis of exclusion rather than leading the differential. They say that bone density is the gold standard in terms of treatment, and one of the problems that they talk about is that the long wait times to obtain them, they think is a barrier to care. In terms of treatment, they say they infrequently manage osteoporosis in men, although they say they're comfortable doing it. They tend to refer men to endocrinologists as opposed to managing women themselves. Again, long wait times are a problem in terms of getting patients started on the right treatment. And obviously lack of time, as for everybody, is always a barrier. So they're relying on the endocrinology team to have a conversation with men about whether they should be screened and treated in the future. So it's kind of sobering when you look at that. And so despite 20% of all the osteoporosis occurring in men and the fragility fracture burden being so huge, the primary care docs thinks it's infrequent. And the disease burden between men and women is actually much smaller than what they perceive, both in terms of the cost and in terms of what it's going to do to our patients in terms of morbidity and mortality. The lack of evidence that they cite is an issue. We have to address this cultural bias where they continue to refer to the disease as something that affects women. And they were relying on us as surgeons to help them kind of initiate the workup to help flag the patients that we think are at risk. So, potential solutions in terms of how we think about this in the future is publicizing guidelines that are already there, just making people aware, building the system reminders in the medical records. This is something I've been working with our institution about, how we flag patients so that it just pops to the top of the list. Building those multidisciplinary collaborations like fracture liaison services to properly manage this patient population. The culture of bias is hard, in discussing this further, some people say, well, we have to empower our patients. And one way to empower patients is to ask their female partners and friends to talk about it more at home, because they're going to be the most effective way to educate men. Not sure how I feel about that one. And then looking at alternative diagnostic modalities like opportunistic screening, because if bone densities, it takes 6 months to get one, well, you're kind of missing that window. So what else can we use? So for me on that, research path of taking one question to the next, the alternative diagnostic modalities and opportunistic screening, there's lots of work that's out there already that says that you can use other things to look at bone density. So CT scans, we get them for all sorts of reasons. We get them for shoulder fractures and for pelvis fractures, and for, we can get them for virtual colonoscopies. There's all sorts of things that you can use. And it is well established that a Hounsfield unit from a CT scan correlates with bone density pretty well. So, we could get these in the ED and give patients an assessment of the bone density without having to wait for a BMD. X-rays, we get them every time we see a patient in the office, right? And so the correlation between measuring the index metacarpal thickness or even the distal radius is also pretty well established. So there's algorithms where you can just use your X-ray in clinic and be able to tell the patient immediately what the risk for osteoporosis is, or at least identify the ones that need further screening. And this is an area that I think is really ripe for new technology and AI, and it's being used in Europe much more frequently than we're using it in the United States, but it seems like it's an easy thing to do. So next questions from there. Well, okay, so if maybe we're gonna order the bone density, we're gonna think about referring to endocrinology, like when do we start treatment? People are nervous about starting bisphosphonates for lots of reasons. And one of them is because it may affect fracture healing. If you look at animal studies that have looked at this class of drugs, they're kind of controversial. In some cases, there's more callus formation. In some cases, there's less. In some cases, it doesn't change it at all. And if you look at all the clinical trials that look at the drugs, none of them report any adverse events that are associated with fracture healing, but those trials were not designed with that as a primary outcome. They're looking at fracture prevention and other things. So their ability to detect changes in fracture healing are not very sophisticated. So going back to my cohort of patients now that I've been following for a long time, it was like, all right, well, let's look at this. Divide the ones who were on a bisphosphonate when they got hurt and the ones who were not. And let's just look at what their healing patterns were. And examining all their x-rays, it really looked like every single patient went on to heal their fracture. Maybe it took a little bit longer, about 7 days longer if you were on a bisphosphonate, but that's not really a big clinical difference. And if you had a more complex fracture, it took longer, as you might expect. Some colleagues in Korea did a slightly different study. So they, probably a better study, they randomized patients who were having surgery for a distal radius fracture to either start a bisphosphonate a couple weeks later or wait 3 months. And they expanded the study and looked not only at radiographic outcomes, but also at how they did clinically. And at 6 months, no difference between the groups. So all the fractures healed, the dash scores were all the same. Everybody was doing pretty well. So I wanted to look at it even a little bit more. So I did a small cohort study of just 12 patients. And what I did with this group is I tried to develop a way to quantify radiographic healing, which we've done as orthopedic surgeons in the tibia and in other places, but not in the wrist so much. So I developed a scoring system and then standardized their x-ray follow-up at very defined periods so that we could measure it, and also added the clinical outcomes like the Korean study did. And again, same findings. So all their clinical stuff was the same. Their outcome scores were all the same. And if you quantified the radiographic healing, it was similar in patients who were on bisphosphonates and patients who were not. So put this all together, doesn't seem like bisphosphonates are associated with any type of healing complications in wrist fracture patients. So if you have a patient, you're gonna fix a distal radius and they should be on treatment, like you should start it. And as surgeons, we really should not be missing an opportunity to start treatment after a fracture if it warrants it, out of a concern for healing. And I think, even in hip fractures, that's been established to be okay as well. So next question from there, what do we do about vitamin D and bone metabolism? So topic that's been looked at extensively in hip fracture patients. We know that lots of our hip fracture patients, over 90% of them, are vitamin D deficient. Again, in New England, maybe a little bit more of an issue than in Charlottesville. But in the distal radius fracture population, hasn't really been looked at very carefully. There was one study out of Norway that showed that low vitamin D was associated with distal radius fracture. And in osteoporosis, you get a uncoupling of bone formation and bone resorption, and that can be measured with bone turnover markers. So there's markers of formation and markers of bone resorption that in patients with osteoporosis are generally higher. And you can look at that as well, and that really had not been looked at in a distal radius fracture population. So we designed a two-center study, again, New England, so it was the University of Connecticut as well as my group. And we recruited patients with a fracture within a few weeks after their injury and a bunch of non-fracture controls. And we looked at their bone density and we looked at all of these markers, and we were kind of interested in seeing, did vitamin D actually matter? And interestingly, we found that our hypothesis that it did was actually not true. We found that, as you would expect, that if a patient had a previous fracture, that predicted a fracture. If they were taking calcium, that was protective. But if you look at that vitamin D, the 25 hydroxy vitamin D, it did not predict a fracture in this particular cohort. So in thinking about it further, especially when you try and reconcile this with the hip fracture literature, you're like, well, why not? And maybe that's because vitamin D only matters if you're really, really, really low. If you're like in the middle, it doesn't matter so much. It's only in the lowest quartile. So we split it into quartiles to try and look at that. And even with that, vitamin D, even in the lowest quartile, with level of under 32, it didn't seem to be predicted of fracture. What we did find is that P1 and P, which is a marker of bone formation, did seem to predict fracture quite strongly. So if you were in the highest quartile of that, your risk for fracture was almost 5 times higher. And then if you combine that with bone density, so if you look at that graph on the left-hand side there, if the dashed line, if you have a low bone density and your P1 and P is high, your likelihood of fracture is almost 80%. So now maybe there's some way that we can measure this, like maybe there's a screening test that we can do in somebody and be able to measure what the risk for fracture was. But it's really only interesting to do this in somebody who's young, because if you take a 50 or 60-year-old, you've already lost a lot of the bone that you made when you were younger. So the idea of a marker is mostly interesting if you could measure it in like a 20-year, right? So did the same study in a premenopausal group. So 20 young women, 20 controls, and looked at the same markers. And without spending too much time on the detail, what you can see from the graphs is that, vitamin D didn't matter. But all of the other markers of formation kind of behaved as moderate predictors with the area under the curve. So they could potentially have some use in terms of being able to predict a fracture in the future. When I sent these studies for review, the comment that came back from the reviewers, which I think was a good one, is, well, how do you know it's not the fracture itself that's causing these changes in bone turnover? And we had picked one particular time to measure them, and we picked 3 months. And we did that because we wanted it to be kind of far from the fracture so that the fracture had healed. But we didn't want it to be a year later because we wanted it to be representative of the time of injury. But because I think that was a good point, that led to our next study, which is, okay, well, let's measure them longitudinally over a year. So we're going to take a group of women who have a fracture and some controls, and we're going to measure their bone turnover markers at 6 weeks and at 3 months and at 6 months and a year, and just see how they behave over time. And what we found from doing that in a rather labor-intensive study is that the peak levels come up at 6 weeks after an injury, and then they slowly kind of come back to normal. And most of them, all of those markers, including the ones that I'd studied before, kind of come back to normal at a year and are similar to control populations, except for 2 of them, sclerostin and DKK1. And I'll show you what that looked like. And then the more severe the fracture, the more the markers go up. and bone density didn't seem to really affect it. So the two boxes on the bottom right of your screen, so sclerostin and DKK1, are the only two that remain different even after a year. Interestingly, sclerostin has become kind of a new kid on the block, even though it's been around for a while as a marker, and now there's medications that look to inhibit it. And so that may be, something that we can look at. Again, very preliminary data, but maybe if we measure sclerostin in a 20-year-old, maybe we'll be able to tell if their risk for fracture is increased at that age, and maybe help them eventually prevent a fragility fracture when they're older. So, no talk about bone fragility is really complete without talking a little bit about imaging. As I mentioned earlier, bone density is still the gold standard. It's pretty old technology. And even though it's a gold standard, it's not always a great predictor. Like, I'm sure all of us have had patients who have had a fracture, and yet their bone density is normal. And if you looked at that very beginning of the first slide that I showed you in the distal radius group, I told you that 2/3 were abnormal size, like 1/3 of them have normal density. And those are the hardest ones to deal with, because you know that they're at risk of a fracture, and yet, your best screening tool doesn't identify it. So there's a lot of people working on alternative modalities to look at how we diagnose osteoporosis. And on that list, there's a few things to talk about. So there's micro MRI. So micro MRI will give you a picture that looks like this, and it gives you an idea of what the architecture of bone looks like. And it will discriminate vertebral fracture better than bone density, and that data has been around for a while. And it's promising as a tool to monitor treatment, but as we all know, MRIs are hard to get. It's costly. It's mostly a research tool at this point. And so in the distal radius population, it hasn't really been looked at very much. There's ultrasound, and ultrasound has been shown to be very good for the central axis and for the proximal femur. It's cheaper. It doesn't use radiation, user dependent. And again, at this point, no data on distal radius fractures. And then there's CT, and CT, for instance, in Europe and in Switzerland and in many centers, like this is what they're using in the ER to even just to image the fracture. And a micro CT will give you the same thing that an MRI will do in terms of what the architecture of the bone is like. So it'll show you what the trabecula are like, how thick they are, how spaced they are, and will give you a pretty good assessment of how the bone is built. So going back to my idea of looking at young patients to try to see if we can figure out who's at risk at a young age, we recruited women under the age of 45 with a fracture and controls, and we scanned their contralateral wrist, and you also scan their distal tibia. And you can get a sense of now what their bone is built like. And again, the thickness of the trabeculae of the trabeculae and how separated they are is one of the main things that you look at. And we also looked at their bone densities. And this is a busy slide, and don't worry about the actual numbers. I think the point here is we had 40 fracture patients and 80 controls that were basically similar. Their bone densities, as you would expect in a young patient population, were also similar. But their CT scans showed that in the patients who had fracture, almost every parameter was different. And I can't tell you what's normal and what's not normal because it's a new technology for this, but it was almost a 6 to 14% difference depending on what you look like in terms of what their bone actual architecture looked like. And those differences remained even when we adjusted for age and bone density. So clearly, these differences in architecture associated with fragility fractures are independent from bone density. And it's measuring something that you're not looking at with a DEXA scan. The use is still limited. It's mostly a research tool for us in the US, but this has also the potential to be able to identify people who are at risk for skeletal fragility at a young age in a pretty quick way. And we now know that if you have a fracture at a young age, you already have an altered architecture of your bone. And so although this is a cross-sectional study and it doesn't allow you to predict what happens in the future, it does suggest that if you have a fracture when you're 20 years old, your risk for a subsequent fracture is higher. This is the last thing that I played with, so reference point indentation. So this sounds really barbaric. It's not as bad as it sounds. But so this technology was developed in Spain. And the concept here is that you create a microfracture in a bone, and you are able to determine how strong, how good the bone is at being able to resist that. So if you think about it, you've got bone density, which tells you how much bone you have. You've got the architecture, which tells you how the bone is built. And then this tells you how strong the bone is. So to do this in the clinic, you basically put a little bit of lidocaine in the anterior tibia, and then you use a small probe, which is like a 25 gauge needle. So it's really not a big deal. And you just touch the bone 10 times, which the patient can't feel. And then you use a block of PMMA cement as your control. And it spits out what's called the bone material strength, or BMSI. It does not have a unit, and that's meant to tell you how well the bone can resist that force. So this was an NIH-funded study, and the idea here was to recruit wrist fractures, recruit hip fractures, and controls, and to look at how this panned out. And as you would expect, our patient populations were slightly different because the hip fracture patients were older and they were less active than the wrist fracture patients, just by definition. They all had high risk of fracture if you looked at their clinical risk factors. And the fracture patients had lower bone density than the non-fracture controls, as you would expect. But all of the other characteristics were kind of similar. And on this table, just look at the very last line. So this is the BMSI. And what you can see is that in both the distal radius and hip fracture patients, their strength is lower than a fracture-free control. Again, I can't tell you what a normal number is here because this is all early data, so we don't really know what's normal, but we can tell you that it's different. And the interesting part is that if you adjust for the stuff that you would want to adjust for, like age or BMI, and most importantly, bone density, the distal radius fracture group, your odds for fracture remain higher. So when you look at BMSI. So again, what it's telling you is that you're measuring something different here. The differences remain when you control for all the other things. We didn't really see that strong an association in the hip fracture population, and I think it's because we were underpowered for it, but it's clearly measuring a different element of skeletal fragility. So it might be a useful thing to predict distal radius fractures, particularly in the patients whose bone density is normal. The company who developed this set it for FDA approval. I don't think we have an FDA anymore, so I'm not sure if this will ever become available for daily clinical use, but it might, and it might have a benefit there. So, what do I do with all this in my daily existence of how I treat my patients? So anybody who comes in to see me with a distal radius fracture, who is either a postmenopausal woman or a man over 60, is going to get a bone density. And I usually just order it myself rather than waiting for somebody else to do it. If they're on a bisphosphonate, they're going to stay on it. And that makes sense. I mean, those drugs stay in your system for a long time, so it makes no sense to stop it. If they're not on it, or if they're not on any medication, I'll usually will start it. So calcium, vitamin D is a relatively easy thing to do. Alendronate is usually what Medicare will pay for as a first line treatment. If somebody has not been treated, it's a once a week 70 milligram prescription. Like most orthopedic surgeons, it's not something I want to be doing long term. So I just write that very first prescription. And then what I do, my system is pretty email friendly. I usually will email the PCP and say, hey, I'm doing this, and now it's your job to follow it. And that seems to work out pretty well for me. The young patients who I now know are at risk is the harder group, because even though I have all this information that tells me that their risk of a future fracture is great, I don't have any great interventions that might prevent that at this stage. So it's more about the things that we know, which is weight-bearing exercise and healthy diet and healthy habits. And it's a start, but maybe someday we'll have something more to offer. And then who do I refer? So anybody who's already been on treatment, who failed it, people who have known metabolic abnormalities, and then people who have lots of fractures that I can't explain. I think those are the ones I typically refer to endocrinology. At my institution, a referral to endocrinology is somewhere between 8 and 12 months. So, I really try and do something before I send a patient on a bridge to nowhere. So to end on that topic, I want to talk a little bit about how we do, fracture care, because I personally think that this is where the future is. Currently, CMS, our PCPs told us that if they're not incentivized, they're not going to do it. So again, I think CMS has not done this yet, but Maybe it's coming, maybe they're gonna wake up one day. Currently, the quality indicators are screening for women over 65, managing the injury, and then doing the pharmacological therapy or falls assessment for people who meet diagnostic criteria. But there's no real penalty or prize for properly screening patients. And I think this is why primary care doctors will, get the A1C under control and do the hypertensives, but don't care about osteoporosis. In systems that have moved more towards accountable care, in Massachusetts, we have a small percentage of that, but obviously in California, it's a bigger group. You start to see more of a shift towards prevention. And as physicians, I think our job is to try and figure out what performance standards we need to use. We've done a horrible job of doing this up to now. So, should we be looking at how many patients we're screening and treating? Should we be looking at how many fractures we're preventing? Should we be looking at how much money we're saving? Should we be looking at all three? And I think this is where, if we don't figure it out, somebody's going to just tell us what to do. So it'd be great if, as institutions address this, you could decide, where you think the appropriate focus should be. The American Society for Surgery of the Hand was very generous in giving me a Bunnell Traveling Fellowship about 10 years ago, and I made this the focus of my work. So what I wanted to do is travel the world and see how other systems in other countries are managing their fragility fracture population. So in that process, I visited Canada and the UK and Sweden, who all have big patient registries and pretty well-established fracture liaison services. And then I went to Japan and I went to Mexico, which are differently resourced healthcare systems and don't have that level of involvement. And it was just kind of interesting to see how all of these people address it. Most interesting was to see that everybody does it better than we do, which was kind of maybe not surprising. What I learned, I'm going to try and distill it in like 3 slides because it's a lot of different things. But basically, there's 4 steps to this process. It's pretty basic. So we in the US, we fail at number 1, and that's identifying the patients at risk. They have registries. When you have a registry, it's easy, right? Everybody who comes into the ED will get flagged, or anybody who comes into the clinic. We don't have that. So if you're trying to set one of these things up in your practice or in your system, the first step is trying to figure out how you're going to identify the patients at risk. Are you going to look at who comes into the ER? Are you going to look at radiology records? Are you going to look at patients who come into orthopedics? Are you going to look at patients who go to primary care? This is the hardest part. The actual investigation of the problem is pretty easy. You just have to decide if you're going to do it when they come in for their fracture visit, or you're going to set up a separate visit. And most of that depends on what your availability is for bone density or whatever diagnostic thing you're going to use, and what your availability is to get some blood work. Again, initiating treatment is super easy. You have to recommend it, you have to start it. The decision there is like oral or injectable, and that depends on what the patient can afford and who's paying for it. If it's Medicare, and it's usually going to be an oral bisphosphonate, because that's what you can get reimbursed as a first line, unless the patient has a bunch of reasons why you can't. And then the last part, and that's where everybody else in the world fails, is monitoring, because they do a really good job of identifying the patients and getting all this started, and then patients go back to the primary care doctors. We know that compliance with these drugs is really poor. And then at a year later, it's really unclear how many people are still taking their meds and doing what they're supposed to do. So if you're starting to think about developing a system, figuring out how to look and measure this over time is also important. A few more lessons is that the system that you design has to work for all fractures. And that is really hard, because it has to work for, the 65-year-old distal radius patient who walks in because they got hurt playing tennis. And it also has to work for the 85-year-old who lives in a rehab facility or in an assisted living, who comes in on a stretcher and doesn't have any family support. So whatever you decide, however you set it up, it has to work for the most frail person you see. Figuring out that monitoring piece is very important. So what the adherence is at 12 months, because otherwise, there's really not much point in starting the treatment if people aren't going to continue it. We haven't spent a lot of time or resources in the US to develop training for either nurses or nurse practitioners or other APP providers. In the UK, when I saw this whole system of fracture liaison services is entirely run by RNs with the supervision of an endocrinologist in a different place. And we just haven't done that, right? But there's definitely a role for this. And if you do that well, then you get to the major point at the bottom, which is, most surgeons don't want to do this. And so if you set up the system, if you participate in setting it up, then your actual involvement in the day-to-day really can be minimal, which I think is ideal and the goal. But what you're trying to do is like get to the pinnacle of this graph, right? So the bottom on the x-axis, you've got your 4 steps: the identification, the investigation, initiation, treatment, and monitoring. We figured that out. And then what the case mix is, I think most places do a pretty good job with hip fractures because they're inpatient and you have them captive and, you have an opportunity to do that. We're pretty good on that front. I think we're starting to make a dent on the outpatient, on the awareness of, for instance, wrist fracture patients who are younger and present this amazing opportunity for intervention. The vertebral fractures, we don't even know when they happen most of the time. So that population is still a mystery of how you go about capturing them and figuring that piece out. And then how you do it. So, I do a pretty good job in my practice. I do a decent job with my partners. Once I expand it to my trauma service, it starts to be a little bit less tight. They do great with the inpatients, not so much with the patients. And that's just like my little team, right? But then that doesn't really help because you have to do it locally, you have to do it regionally, and you really have to do it nationally. And if you accomplish that, then suddenly, as lonely hand surgeon here in my practice, that's my ability to have a massive impact on patients in terms of not just fixing their injury at the time, but also in more on a public health setting of really trying to change their long-term outcome and prevent second or a third fracture that may in the end be the thing that keeps them from doing what they want to do and eventually leads to their mortality. So that's basically what's kept me going for this time. And I'm happy to entertain any questions.
First of all, thank you very much for that presentation. I hope you don't feel bad that you are preaching to the choir. All of the things that you have identified, we went through about between the last 5 and 10 years and have hopefully moved the needle. We have a fracture liaison service. We have a nurse practitioner who runs our fracture service. We try and capture everybody over the age of 50 who has a low energy mechanism fracture. Some of that's through education, through other services, spine service, the hand service. I'm the head of the trauma surgery department here. So we capture the trauma patients well, but we try and capture through all the other services as well. And we've seen a steady increase in referrals. I was really interested in your talk about micro CT because I think that you're right, bone mineral density is probably a very crude measurement of resistance to fracture. And there's probably some architectural things where you might have denser bone after treatment, but maybe not supportive bone. Just because it's thicker doesn't mean it's actually working better. So that's really going to be some cool stuff. Hopefully that comes out. Just as a statement, I think that I'm glad to see that Harvard struggles just like we did for some of the things that we tried to set up, but we were eventually successful. Like an oil tanker, we eventually moved the needle and changed the direction. But you're right, there's no reimbursement. The intervention, the financial intervention is not really there. I was curious about the osteoprobe because I think that that's an interesting technology, but because bone mineral density and cortical thickness changes so much, even in small locations, how would you reliably put it in the same place or a place that you know to be the same on person to person? Because particularly like around the proximal tibia where you were showing it, I mean, if you're on the tibial tubercle, your numbers are going to be a lot higher than if you're just a centimeter away, off to the side of the metaphyseal bone. And we know that just from operating in this area all the time, your drill torque is much different in different areas depending on where you're directing your screws. So I was curious how you would do a reproducible measurement in that area.
You try, there's obviously the technique will tell you where you're supposed to be, but there is a ton of variability. I mean, the biggest struggle that we found was in terms of the amount of soft tissue. So the technology doesn't work very well in a big population.
Well, I imagine too, a younger patient would have thicker periosteum. And so, are you maybe getting some feedback off the periosteum? I think there's some interesting new technology that's coming along on ultrasound, shear wave elastography, and some different ways of measuring, using it for looking at fracture healing, but may also be good for bone. There's some technologies on the horizon, non-invasive, that may be helpful in this case too. But it's a very interesting topic. But thank you for your presentation. Dr. Sharma and I were happy that all our work had come to fruition.
So our bone fragility clinic is here at the Ortho Center, and our NP sees patients every day. And we get referrals from endocrinology because they can't get patients in, and we can. And she has a full-time practice doing bone fragility. Not only, I mean, we're the biggest, obviously, it's in the clinic, but also from endocrine. So the relationship with endocrine has been the challenge to develop, right?
We have a good relationship, the same problem as you. You know, you send a referral in 6 months, or they send a letter saying they can't see them. Like, you might as well send them to the community because we're not going to be able to see them in any length of time. And so by setting up the center would help.
So institution dependent, whether you have an endocrinology group who happens to have an interest in this. I mean, we have some actually pretty strong bone people in our endocrine group, but they don't have any interest in really collaborating. You know, across the street at the Burgo, they happen to have an endocrinologist who's really interested and who will kind of take ownership. So it's, you know, it's institution. I think honestly, the biggest challenge is what do people in private practice do? It's easier if you're in an academic setting and you've got that support system, right? If you're in private practice, you see this rate fracture patients, then what are you supposed to do with that? And they refer it to your clinic.
Yeah,
they do.
Yeah, we get we tried to advertise that, you know, and we run classes here, like balance classes for the community. We try and advertise with physical therapy groups who are, you know, seeing patients who might have been going to physical therapy from fragility fracture, and you know, and so we and our there's a community hospital in town that we've tried to advertise, you know, market, essentially advertise the presence of the clinic. So it's been slowly growing, and it's a very valuable tool because again, we can get people seen much sooner. They can get started on treatment. Also, the new treatments I think are also, there's some promise there. Bisphosphonates, obviously, people are hesitant to go on them, but the newer treatments don't have quite the same length of track record. So obviously, we don't know if 10 years from now we're going to start finding problems with those, but there's a lot of new treatments in the pipeline that have some promise for improving things. So hopefully that'll help.
This impacts all of orthopedics. Maybe not so class. I guess facial fractures, should they get screened and bring them in?
So I may have a biased perspective because we have oral surgery in our department, but we see a lot of osteonecrosis of the mandible after bisphosphonates, and it's really challenging to manage. Is this something that you talk to patients about, or do you kind of defer that to the PCP? And I guess what's the true incidence of that?
So that's a great question. I spend a ton of time with my patients talking them into starting a bisphosphonate and not worrying about that because I think the incidence, I mean, obviously, I think you probably do have a life perspective because you see all of it. The incidence is relatively small, and your fracture prevention is 50%, and that's a staggering number. So, it's sort of the balance of risk and benefit. To me, the benefit of preventing the new fracture is greater than the potential of having a problem routine. That being said, I think if we often will encourage patients who are starting to get a dental exam before they start, whether they actually do that or not.
And we have the same problem with the atypical fragility, with the atypical femur fracture. So the bisphosphonate-induced femur fracture. So when I talk to my colleagues in the orthopedic trauma world, you know, that's their thing. Like, oh, atypical femur fractures. And I'm like, yeah, but if you look at any of the big databases, if you look at Kaiser, if you look overseas in the Norwegian registries, the number of fractures prevented is so much higher than the number of new fractures. So yes, you're going to have a 1% risk of a fragility fracture, or maybe a 0.5% risk of osteonecrosis jaw, and those can be big problems. But if you have a 25 or 30 or 50% risk in the population, the problem is those numbers apply to everybody, and you're talking to an individual patient. And that's what we always say is, you know, the numbers would suggest this is a good thing for you. However, on an individual basis, there are risks, and we just can't drop that risk to zero. But again, some of the new medications may be helpful.
Sure.
So how do you think we do incentivize primary care here? I think that's the fundamental challenge, is that you know, we are basically becoming primary care. You know, and I think that extending it to extenders is probably where things are going, I would say. But access to other subspecialties is really a challenge too. I mean, rheumatology is 8 to 10 months out. Endocrine is 3 to 6 months out, maybe if you're lucky. And so in the end of this, if you're having follow-up with patients, they're not getting appointments with any of these people in any of your parameters that you're seeing. At least we're not experiencing that here. So how do we incentivize that component of it? Or is there a way?
I mean, so I think you're right that it's a very challenging thing. Obviously, there's financial incentives, and some of them are going to be built by payers. And some of them can be created by health systems potentially. But I think it's difficult to incentivize them to always do the right thing. I mean, I do think the electronic reminders will help. Like if there's an Epic checkbox that forces you to do it, you're more likely to do it. So, but it's amazing. We switched to Epic just in July of last year, and we're 8 months in, and I have been working with this team all the time. Somehow it's really complicated to get an Epic reminder that goes out because it has to go through 50 million different committees.
I can speak on that too. We had the same problem about 5 years ago when we were like pushing to get the fragility fracture clinic open. We wanted to do a best practice alert, which is an Epic reminder. And we interfaced with our primary care physicians in the area and some of the internal medicine people to try and figure out, because we can get BPA fatigue too. We had a sleep apnea one that would fire all the time, no matter what you were doing. And it was just so annoying because it had nothing to do with what you were doing. So what we did instead is we decided that since almost anybody with a fracture was going to be sent to one of our clinics for treatment, that we would really focus on the treating physicians to then refer them and then get them back to their primary care. The primary care, generally speaking, we're happy to manage them once it was identified. And so the real key was the screening part. And so when we interfaced with them about the BPAs, they were sort of a little hesitant because they're like, we get so many things about stuff. And so one of the challenges, and so we chose not to fire the BPA. We still haven't, we could still do it. It's still left open, but we had the same challenges of months and months of back and forth.
It was interesting to me is that I've just always assumed like the endocrinologists have these guidelines. We follow them. Well, it turns out that the primary care docs, that's not what they follow. They follow the family physicians and primary care guidelines. And they actually don't have guidelines for screening, particularly for instance in men. They just don't exist. And so the fact that the endocrinologists have them is not good enough. Because that's not the organization that they follow. So, getting them all on board when you're looking at a group of internal medicine trained people and family practice people, and sometimes even pediatrics. So I don't know.
System issue and a focus on prevention rather than treatment, which is this country has still not made that jump.
Right. So I don't know. I've taken it upon myself to make my job to try and just educate them. I think in a smaller health system like that can work because now they know if they're seeing one of my patients or I'm seeing one of theirs, like they're going to hear about it, and so they're a little bit better about doing that. But that's that's again local versus regional or national, and that's a big difference.
Yeah, well,
I mean, this conversation comes up all the time. They can't see endocrinology, they can't see rheumatology, but they need to see these people. What's preventing us from having these people under our department so that we can, Dr. Charman, both of you, because it's the same conversation all the time, and I just don't understand. Because we cannot do that, so why do other services get to say we're not going to see them, right? But we're dependent on their services to make sure that our patients are healthy. If not, they come back again and they break something, and it's a QA. So it's like the solution doesn't make sense. What do we do?
That's probably a question that has to do with aligned incentives, right? So those services are not high revenue producing services for institutions. So institutions don't have a lot of interest in expanding and investing resources in hiring endocrinologists who are not necessarily going to make money. Because of that, they're hired, again, different institutions are different, but in my institution, those folks are hired in salary models. We're in a heavily incentivized model. So we're incentivized to see lots of patients. They're not. They can't be on an incentive model because they'll never make their salaries. So there's some health system challenges that can be difficult to overcome. But I fundamentally agree with you that in some ways, like maybe you shouldn't get quite as much choice.
And I mean, unfortunately, you get paid a lot more for operating on distal radius fracture or treating one non-operatively than you do for screening for osteoporosis, even as an office visit, and seeing the patient back 3 times, which takes a lot of time too, which you don't have.
So I just went straight to Dr. Weiss because I know how passionate he is about this topic. So that's something that, as you can see, we've been working on. But what I wanted to showcase here as Dr. Rozenthal pulls up her next talk is, she's done a tremendous job in terms of researching this topic throughout her career. She did the Bonnell Traveling Fellowship, which is the most prestigious traveling fellowship for the ASSH. 2 years ago, she won the Andrew Weiland Medal for Lifetime Achievement in Research, which is the highest honor the ASSH can provide. And obviously, she uses evidence-based medicine with all her decision making and has created processes and patient care processes that she has implemented not only in her practice but at her institution. But it's a remarkable show of clinical research and how she's used it and the experience she received worldwide during as a traveling fellow. So it's really remarkable, and congratulations on all these accomplishments. Before we start our second lecture, I want to talk a little bit more about the hand fellowship program and the hand service started by Dr. Morgan and Dr. McCue. Ray Morgan, of course, was chair of plastics here for some time, and one of my partners. He trained me when I was a resident. I probably was a pain in his ass, I'm sure I was. But I was his partner for years too. When I started here back on faculty, Frank McCue was my mentor. And here in orthopedics, he was the head team doc. He was sports and hand trained. He was here on faculty for 42 years. He passed away about 12 years ago. But he gave me a job and allowed me to take care of UVA athletes. And I took over his hand practice. So, but the two of them created the foundation of the hand program that, when they added me, and now we're up to 7 hand surgeons and 2 APPs, so we've become a big service and a collaboration between ortho and plastic scan. And we've been very fortunate. We've had the last 5, the current ASSH president, but Marty Boyer, Jeff Greenberg, Jennifer Wolf, Steve Moran, and now Tamara Rozenthal have been our visiting professors 5 years in a row. So
You're gonna do next year.
I don't know if anyone want to hear me speak, right? We'll find someone. But we've been very fortunate to have the leaders in hand surgery here at our program. And also for 4 years in a row, we've been a site for the ASSH International Traveling Fellows. So we have a very strong hand program here and we're very proud of it. And it's because of the foundation created by Ray Morgan and Frank McCue and the opportunity I was given by both of them when I started here to build the hand team. So thank you, Dr. Morgan. Of course, thank you, Dr. McCue. Thanks to all my partners and my department for being so supportive and the collaboration between classes. So let me go on to the next topic. Yeah.
We have to move on back to.
Okay.
Yeah. And just real quick, I'm going to have to leave, and some of our faculty are going to leave. I want to thank Dr. Rosenthal. Also want to thank Dr. Chabra for hosting a nice event last night, and also Dr. Morgan for being part of this. Really, the highlight is the collaborations we just heard from Dr. Chabra. So, thank you.
Something lighter. And I'm supposed to give people life advice, of which I really don't have very much. So this one's a little different and maybe more personal than I'm used to talking about. So bear with me, and if you hate it, I won't be offended if you walk out. But topic of the day was, can you have it all? And I will say that I've generally been a proponent of saying that yes, you can, but it's not always easy. So the first step of this fun balancing act is just trying to figure out, what it is you want. So this is me. My first day of residency, you can see I'm like pretty lonely with a bunch of gentlemen. And a couple of years later, we're up to 3 in my program of 42. But you finish residency and like the world is your oyster. You can do whatever you want. And to me at the time, I was unaccompanied. My family lives in Mexico City. I had no geographical limitations. And so I could really pick absolutely any job or any type of career that I wanted. And then unfortunately or fortunately, somewhere along my PGY 4 year, I met somebody, and next thing you know, I'm getting hitched. My husband is an architect, and he's got his own career aspirations. So now we have to balance 2 people, which makes it slightly more challenging. I was pretty clear on what I wanted. I was very committed to a career in academics. So I ended up taking this job at Harvard where I still am. And so the concept there, so it's an academic job. It's an academic appointment at a major med school. So we're a Harvard Med School affiliated, right? And Harvard likes to make life complicated, and they have a very challenging promotion metrics. So I knew that at the outset. When you start there, you start as an instructor. You're not even allowed to be an assistant professor for about 3 years. I came with the responsibility of having medical students, residents, and fellows, which is something that for me at the time I wasn't sure I really was that interested in. I was more driven by the research side than I was about the teaching. But I had this longstanding interest in research, and I wanted to continue that. And to make matters a little bit more interesting, the financial arrangement in my practice there is like a private practice. So I get a monthly profit and loss statement. It's what you did and what your expenses, and I'm like responsible for all of them. It's tied to my collections in cash. It's not RVU based, so like my payer mix and those things matter. And I have zero financial incentive for teaching or for doing the research, which is why I took this job to begin with. So that's just like sort of setting the stage for what the challenge was. And then I also knew from the beginning that I was interested in doing stuff at a national level. So it was the Hand Society or the Ortho Academy. It's something that I wanted to be involved in. And as I mentioned earlier, I was a two-career couple. My husband, had been working for a long time. He's a little bit older than I am, 7 years older. So he'd already had a career, and he was not really interested in giving that up. And the two of us were interested in having a family. So, if that's not the definition of wanting it all, I'm not really sure exactly what it is. So why, how do you go about balancing this academic agenda with clinical care and why you want it? And so I found it helpful, at least for me, to remind myself often of why it is that I wanted to do this, because it's easy to get derailed along the way. So I was interested on the research side, mostly because, like many people who do this, I wanted to fill in the gaps in knowledge, and I wanted to improve outcomes for my patients. I wanted to make sure that the quality of care that we provided was better, and wanted to advance that knowledge. And as I went along, I found out that actually I enjoyed educating the next generation, and I found that to be pretty rewarding. And so in some ways, it's kind of two sides of the same coin. It's the interdependency of the clinical agenda and the research agenda. And in a lot of ways, as I just talked about, my research has informed my clinical practice, and so they build nicely on each other. But there's tons of challenges along the way, and the biggest one is time, I think, for everybody. And then it's what the resources are that you have available, what the knowledge gaps and what you can actually bridge, and then money. It's always money, right? There's never enough. And then teaching and research involve different skill sets, and you're not necessarily equipped when you come out to do both of them equally well. And so when you start your practice, you're obviously trying to learn how to be a decent clinician, and at the same time trying and learning how to be a researcher. And so that can be a big challenge. I think over the years, as I've evolved, time management is probably like my superpower. If there's one thing I know how to do, it's this. And I think you figure it out as you go, and it evolves. But prioritizing tasks becomes important. So trying to differentiate when you're going about things between what's a task and what's a project. A project's going to be more long-term. It's going to take maybe a year, maybe 2 years. A task is just something you just got to get done. And you get those done quickly so that you can focus on the longer-term goals. This book that I mentioned here is from a lecture that I heard a few years ago that talked a lot about delegating, and about how anything that you can delegate, you should be delegating. And you should be saying no to tasks that are low value and things that you can teach others how to do. This obviously assumes that you have people who you're working with who are going to be there for a while, because teaching takes time. And so if you're in the model, which we've seen after COVID, at least at my institution, where it's like an admin queue 3 months, that becomes difficult. But if you can get a steady team around you, that definitely works. And then obviously using technology when you can to streamline tasks. I know people use all sorts of different ways to manage their calendars. For me, it's my email inbox. That's my to-do list, and it always has to be 5 things or less. And that's the rule at the end of every day. Establishing boundaries, that's a very personal decision about how you want to establish them. I admittedly am not necessarily very good at that. I tend to be quick to respond. That's okay. I don't mind it, but you can choose to do it differently. Running my practice in an efficient way is what allows me to do all of the other stuff that I want to do. Like if I'm stuck in the clinic until 8 p.m., none of the rest of the things I want to do are possible. So I have my guiding principles, which I'm happy to share with you. And again, personal things, so take it or leave it. But my goal is to walk out of the building 15 to 30 minutes after the last patient leaves. And I do this almost every day. I found that if you run on time in the office, it's pretty easy to have short visits with patients and they don't complain about it that much. Once you run behind, like they own you. You know, you made them wait for 40 minutes, they're going to have you in there for a long time, and that's just going to worsen throughout the day. The way I go about doing that is through preparation. So I spend about an hour before each of my clinics pre-templating my notes so that they're ready to go. And I've reviewed the studies and I've made a plan. And so actually walking in there and executing it doesn't take very long. And every single note, I'll show you what they look like in a minute. Everything has everything I need. So I never, ever have to go digging in the chart. Every study that I've done and every injection that I've done is all documented and I just add to it. I never let more than 2 or 3 charts go by without dictating them so that I don't end up with a pile. And whatever I need to do for that patient, putting orders, send an email to a referring doc or whatever it is, I do it immediately after that visit so that I don't have to do it later. So this is a clinic note before we move to Epic, but like this is what they look like for me and literally everything I need, right? Every injection I've done, every surgery I've done at the top, what the x-rays were, what the EMG was, so that I'd never have to go back and spend time digging through the chart to figure out what the heck I did last time or what I was thinking. And that just makes the clinic move quickly. I have my similar guiding principles for what my OR life is. So I try and really minimize the paperwork that I have to do at the time of surgery. And I want to avoid phone calls because I don't like them and my EPP likes them even less. So all the stuff that you can do ahead of time is done ahead of time. So when I'm like working through clinic to get it ready, my APP is often working through the OR. So the HMPs are done ahead of time. The instructions are done ahead of time. All of the meds are sent to the pharmacies ahead of time. When my scheduler books them, confirms the pharmacy and the allergies to them, that's all in the system and ready to go. Our residents and fellows will roll out all the splints at the beginning of the day so that they're ready to go. So all of those things save you like precious minutes in each patient. And because I do many of my cases in a fast moving surgery center, it just allows me to just kind of keep focused on the OR and not to get derailed with all of these other things. And then the fact that you're communicating it to patients ahead of time just means you get less questions later. For me, the be present, always present, like I never ever leave because the minute that I go away, everything just grinds to a halt. So I'm always in the room. And even if you know, people are busy doing something, I can answer my email in the OR room so they know they're there. And you know, when people say, like when I said in my earlier slide, don't do low value tasks, this is I don't consider turning over the room a low value task. So I do this all the time. I mop the floor, I help take the trash out, I bring the stuff in, whatever it is to just keep the flow going. And usually it ends up motivating the staff in the room to try and move it along as best I can. And again, like if I finish early, I get to go out and then I can spend time doing research if I want to, or spending time with my family. But I know that not everybody likes to be quite this crazy. So. I don't know whether all of you work with APPs. Like to me, it's a hugely important part of my practice. I like to just remind people that APPs are professionals and their job satisfaction and their growth really matters. So although you're going to design a model that works for your individual practice, you have to do it in a way that meets their goals. So for me, my APP will see all my patients in pre-op and review all the instructions. And she does that because she doesn't want to get the phone calls later. So it actually helps for her to, and then she also will see them in post-op, right? So that she'll get that continuity. She assists in the OR and she follows all of my patients for 3 months during that global period. She also has an independent clinic where she sees her own patients and she helps me manage much of the patient phone calls and emails. The things that she does not do is like, she's not a scribe for me. She doesn't see patients for me. She doesn't manage like my problems. We work very much as a team, but the way we design it just helps maximize throughput. So the way I choose to do it is like, I see a lot of the new patients and she sees a lot of the follow-ups. I have partners who flip that model completely around and have their APP see all the new patients and then they do the follow-ups. I think that's a very individual choice about what works best for you. But I have found that this model works very well and I've been with the same person for 10 years. I consider the fact that she commutes an hour and a half each day, each way, a good sign that she's stuck it out for this long. So the research and teaching that we were talking about, so how you go about this and like create the time in your practice. So For me, it's just I carve out a few hours every week, and my schedule changed a ton as my career evolved. When my kids were young, this carve out was like early in the morning before anybody else was awake. Now that I have older kids, I can come back home, have dinner with them, and then work afterwards. So it's not a set in stone. It can change as you go along. Having a research assistant in clinic, if you're doing these trials where you have to enroll patients and spend a lot of time consenting, is super helpful. And like you, if you work in an institution like UVA, you have access to lots and lots of students. And if you share we don't have any institutional support to pay for this, but if you take a research assistant who's a recent undergrad looking to go to med school and you choose to share that with 4 of your partners, it is not a whole lot of money. And it makes your ability to run research effectively much better. And it also, and then you can leverage all of those institutional resources like IRB and statistics, but having, somebody just parked in the clinic where you can walk out and say, please enroll this patient for this study, and they go in to do that, it saves you the time and it makes it feasible. And then you're also going to help them get into med school. So you're actually doing something good. In terms of the money, it's always hard, but like there's a lot of funding sources out there. And I don't know that I was aware about what all the different choices are. And so some of it might be your med school, it can be hospital, foundation, federal, and to just knowing what's out there. If you can incorporate your research and your teaching into your clinical practice, it obviously adds satisfaction. It also adds a new level of efficiency, right? And I think the biggest advice that I give is try and create synergy and collaboration wherever you can. So I take care of a lot of just distal patients, like I'm going to do research on that topic. So my patients become the subjects to the research and you have access to them. Like the people in the lab don't have that. And that is the biggest downside for them in terms of their ability to move projects along, is access to patients, which we're so fortunate to have. So the more synergy you create, the better it goes. This advice was given to me as I started my academic practice, which is when you can develop a strategic focus, because then you become known for a topic. And so I think that does help versus having projects all over the spectrum. And then you have to obviously adapt to the continuous environment of priorities and politics, and you kind of have to look at your progress every now and then and decide whether you're doing it right and review the effectiveness of your strategy. So keep just in mind that it's a dynamic process. It's not a one-time thing, and getting a lot of feedback from your team and your collaborators about what's working and what's not. That being said, like time and persistence are still super important, particularly the persistence part, because things don't always go well. Your grants don't always come through. Your research assistants leave. The project doesn't show the results that you thought it was going to show. So you really have to like it and just keep at it if you're going to be effective at it. Mentoring is a huge part of this. And so I'm going to just talk about this a little bit. So the word, so it comes from the Odyssey, right? So mentor guides Telemachus during Odysseus' absence during that time. And so it's been adapted at this point to mean an individual who's sharing wisdom and knowledge. But I think we use the definition more as somebody who's going to develop our talent and our skills. And as surgeons, this is obviously familiar, right? Because in surgical mentorship, that dates back to medieval times when surgeons learned how to be surgeons through an apprentice model. And that changed a little bit later with the introduction of residencies in the 1890s. And the models continue to evolve, but I think the basics are the same. So what is a mentor? It can be lots of different things, right? It can be an advisor, it can be a networker, it can be a role model. The goal is that it's an ongoing relationship. It's going to help you develop your goals, provide you some career guidance, and then maybe help with personal growth. The key things to remember on the mentoring side is, number one, this has to be driven by the mentee. So your mentor, whoever that may be, for whatever that may be, is going to be a busy person. Maybe they're going to have a lot of other mentees and they're going to have a lot of other responsibilities. So you may not be number one on their mind all the time. So you have to be the driver. And the goal for your mentor is to try and build capability and self-reliance. And they can assist you to highlight the things that you need to focus on, and they can help you plan, and they can help you clarify your perspective. Ideally, they're bringing an impartial view, and sometimes they might give you advice, right? And in that process and in that relationship, the confidentiality and the trust is super, super important. And don't mess that up. The thing that a mentor is not is your goal as a mentor. Like, your job is not to deal with somebody who's underperforming. It's not to do your mentee's work. It's not necessarily to promote and sponsor them all the time. Like, sometimes that happens, but it's not an expectation. And it's not a space for you to necessarily resolve your personal issues or to allow people to complain. So when you're the mentee, you got to keep that in mind. So I think if you're going to if you're going to look for a good mentor, there's lots of different kinds, and you might respond better to some than others. But the idea is you have to find somebody who you're going to be able to build a rapport with and have a good communication with. It's going to give you honest feedback and is going to question and push you. And some mentors are more like guides who are going to explain how to do stuff. Some might be more probers and challengers, and some are my favorite kind are like the unseen and unfelt role models that you're just kind of emulating from a distance, but they can be very valuable too. The relationship building with a mentor takes time, and you have to build rapport and trust. It's good to have some ground rules, and maybe you voice them and articulate them formally. Sometimes you don't need to, but it's good to at least agree on what the goals are of what you're hoping to accomplish and what you hope your mentor is going to be able to do for you. And it's also good to assess the progress along the way, because like mentoring relationships are not, it's not a marriage. It doesn't have to last 40 years. It can just be a finite period of time where you need something. And sometimes they are a lifetime, but it's nice to know that kind of ahead of time. And sometimes if the relationship ends, closure is good too. Being thankful and moving on, or allowing that person to move on to doing something else. Personally, I think it's never too early to find somebody. My mentors, I've had some who I've had all along, and then there's some who have changed and developed over time depending on what I needed at that point. So, if you're starting out as a resident or a med student, like where do you go about it? So a lot of hospitals and institutions will actually have mentoring programs that will connect you with people. So that's a decent place to start. I think the ASSH tries to do a good job with this on the research side. So there's a committee that specifically will help you, for instance, review grants and give you feedback on that. There's the Young Leaders Program. So if you're interested in learning some leadership skills, you can do that as well. The ORIEF has mentored research awards for a more general orthopedic audience. So there's definitely a lot of options, and you can take it to the national level where, the NIH has actual mentored awards. So if you want to spend 50% of your time doing this, I never did that because I wanted to be more than 50% clinical, but you can choose to do a K award and dedicate half of your time to research. And then things like the National Science Foundation, National Academy of Science, all have awards that specifically build in a mentoring component. So it becomes a decision about how much time you want to give to this. Then there's the question of who do you ask? And I think here for me, like the most important thing is this concept of mosaic mentoring, different people for different things. It doesn't have to be one person who mentors you for everything. Like figuring out how to run a busy practice may be different than teaching you how to be a chair or teaching you how to be a good researcher. All of my research mentoring came from PhDs in the lab. And, they write grants all the time. I got all my grants rejected until I had a PhD look it over and teach me how to do it. So figuring out who the right person is for that task, I think is important. It takes time to build. It can start like super easy, just a brief call or a meeting, and be reasonable in your expectations. I think be reasonable of what the other person's time is. I think it helps to go in with a list of specific questions for what it is you want to try and accomplish and get out of that relationship. Again, you have to be the driving force. That's really important. Whenever I meet with a mentee, a future mentee, I tell them that right off the bat, like I'm going to forget. So if you don't email me and tell me that you need to meet or need to do something, I am not going to be the one who's going to initiate it. It's good if you're the mentee to provide updates, and they don't always have to be an ask for something. It can just be like, hey, I want to let you know what I've been up to. For residents, like if you're going to ask somebody to write you a letter, and you rotate as a PGY2, and then you call them 5 years later and say, can you write me a letter? That's a really hard letter to write. If you've been keeping a person abreast of everything you've done every 6 months or a year with a short little email, hey, just letting it becomes so much easier to know what you've been up to. And then on your side as a mentee, like be very responsive to emails and calls. If your mentor emails you or reaches out, like follow through and be thankful, because all these people are investing a ton of time into your development. So in summary, it's a contract, right? It's like any other. So discuss your expectations, clarify what the roles are, and agree to what your logistics are going to be. Keep some type of structure and check in on it regularly and find out if it's still working for you, if it's valuable, are you achieving your goals? And then most importantly, keep whatever goes on in that relationship confidential. Talking about leadership, you know, I don't know, I didn't learn anything leadership related when I was in med school, like zero. So if it's something you're interested in doing, you have to be equally proactive in figuring that out. So I mentioned earlier the Hand Society. So if you're going to be a hand surgeon, there's this great Young Leaders program. Dr. Chabra and I actually figured out that we met during the Young Leaders program. It was so memorable that he doesn't remember meeting me and I didn't remember meeting him. We figured it out this year.
2007.
But anyway, you can do a program like that, and you'll spend some time with, you know, the Hand Society. You'll spend time with the senior leadership, and you'll come in and sit on a board meeting and find out how these organizations work. The Academy used to have a leadership fellow program, which is now defunct, but I went through that as well. And then just a couple of years ago, I did ELAM, which is an executive leadership in academic medicine, which is specifically designed for women in leadership roles. But there's lots of these things out there, and so if you're interested in learning how to do it, again, it's time away from your practice, but it's worthwhile. And I think, you know, you have to seek out these opportunities and to seek them out often. Like I get rejected. I got rejected a lot, and it's okay. Like, it doesn't have to dissuade you if you don't get it the first time around. I think the main thing is that the leadership jobs are challenging for full-time surgeons because they take time. So you have to want it and you have to like it. I happen to think that it just adds breadth to my life, and I'm not just doing clinical medicine. I like the research side and I like the leadership side. But you also have to build a professional network as you do this. And I think actually that, you know, we'll see what Bobby thinks, but I think that's the most rewarding part in some ways, is that you get to meet people from all sorts of institutions in lots of different places. And now you have people who you can call on, not only for clinical questions, but, you know, when you have something on the education side or on the research side, or where you're trying to help a resident or a fellow get a job. It's just this huge resource of people who you've gotten to meet. And developing a network also takes time, and it's a sort of directed, deliberate task. It doesn't just happen by itself. So you have to choose to want it. You know, the stud over here in this photo has also spent some time developing the ASSH Leadership University. So it's a bunch of online modules that you can take at your own time that goes through all of those topics that you might want. And, you know, like, how can you resist them? So, you know, my leadership lessons so far are the following. So when you're in a room, like, I like to be the voice of reason if I can. And then this is one of my favorite quotes, like, the plural of an anecdote is not a fact. And so sometimes, you know, like, stuff is going on in a meeting room and you're listening to it, and it's nice to be the voice of reason and to try and maintain your thinking kind of data-based. For me, that's really important. I think it really helps to be prepared, because just like I do for my clinic, like, if you prepare, you set the framework. So if somebody says, you know, who wants to volunteer for something, if you volunteer to do the first draft or something, or the outline, like, you're actually in charge of controlling the message in your first go. And so you develop the framework, and then people work off that. I happen to be a big believer in transparency, because I think if you show everybody what you're doing and everything's public, then that automatically leads to trust. You know, there's different views on that, but that's kind of my take on it. The last one is like a little bit of an anti-surgeon thing. And so it's not always easy to remember, but that's avoiding the sort of public gotcha of other people. Ideally, you want to empower people to be able to tell you something difficult, and you want to encourage dissent, because I think it builds a dynamic department, and it builds a breadth of opinion. And all of those things are important in making good decisions that are good for people that are more than just you. But, you know, I think sometimes in surgery, we get used to this sort of idea of that, like, aha, I got you. I asked you a question and you didn't know the answer and you were not prepared for that. And so sometimes I find I have to fight against that tendency when I'm in meetings. You know, new generation, we talk a lot about, like, self-care and wellness and how you do this, right? So you're doing your practice and you're doing leadership stuff and you're doing research, and, like, how do you keep your sanity? And so you have to figure out what your individual brand. So my individual brand involves some sweat equity. I like to suffer. So whether it's on the bike or, like, running distance, whatever it is, like, that's how I keep myself happy. But again, this is a super personal thing, and it'd be different. You know, this is my daughter when she was 7 years old, meditating, and my oldest daughter finds it in her artwork, and my husband finds it in his photography. So whatever it is, whether it's your hobby that, you know, like, keeps you grounded and centered is important, and you have to give those things an appropriate amount of time. So, to wrap up before I bore you too much, I think in conclusion, I think you actually can have it all. I think you just have to define your priorities in terms of work and your life. And this notion of balance is elusive. And I know Bobby and I've discussed this and disagreed on whether the balance even exists. I think it's, it's precarious and it's always moving. I don't know that you can have it all always at the same time. So I think that's what I've really come to learn, is that number one, your priorities evolve over time. The notion of a glass ceiling, like it's definitely there. It can be in different places, but it's definitely there. And sometimes you're just up against it, and that's just as far as you're going to go. And that's okay. I have this little video, which I'm debating whether to show you or not, but I should show it. Okay. So a couple of years ago when I was doing ELAM, one of the tasks that we were given was to try and define what was important to you in a job. At some point in time, every single person in this room, if it's not happening already, is going to go through the process of saying, like, am I actually happy doing what I'm doing? Should I switch? Should I move? Should I look at another opportunity? And I was in the process of considering a couple of job switches, and I was trying to decide what to do. And so I put this little video together about what I valued in my job. And as I put it together, I realized that I, in fact, have 90% of what I valued. And so maybe moving didn't make a ton of sense. So I wanted, see if I can play it. I wanted to work in a place where I had inspirational and supportive leadership. That's really hard. I don't know that I necessarily have that in my current setting. So I wanted to work in a place where we had strategic alignment with the hospital system, which is also hard. I wanted a collaborative work environment. So I have an amazing team of partners who I work with, and I wanted a place where there was room for growth. And that's both, in the clinical and the research arena. Mentorship is important to me. I love being able to work with residents and with fellows. We have a fellowship that is near and dear to my heart, and that was important. And my family, we're a really tight-knit family. I have 2 kids. These videos are a couple years old, so my daughters are a little bit older now. They're ski racers. I want to be able to go to all of their ski events. I want to be able to cheer them on. As I mentioned, I like to sweat, so my husband and I enjoy spending time on bikes and running some races. Our family enjoys travel, which is important. I wanted a job that gave me the time to volunteer for the things that I wanted to, and the ASSH has been a really important part of that for me. And so I needed the space to be able to do that. I wanted to live in a city that was really well connected for travel. My family lives in Mexico City. That's where I grew up. We like to be outside. I wanted to be able to get on a plane and go do all the things that I like to do and visit my parents. And, not every city in the United States is necessarily well connected to be able to do this in 3 or 4 hours. So again, as I was thinking about what I enjoy and what I don't enjoy, all of the things that are wrong with my health system and how frustrating it can be sometimes, you realize that I have a lot of the things that make my daily existence really great. And so sometimes, you're willing to put up with some crummy leadership and some health system changes that I might not like in order to keep the overall balance in a good place. Thank you.
Questions?
One of the things, great time. One of the things I always think is interesting or to know about someone who's super highly functional when you have that thread that goes through your research and things like that. Just knowing your schedule and like tonight, I know you have to fly back. You probably have council talk tonight. For us who are junior folks who are getting there, how much time on a Wednesday night are you up from 7 to midnight, pumping out papers and reviewing grants and things like that? Or do you just work it into your week?
I'm mostly working in my week, and as I mentioned, my schedule has evolved a lot. I think when my kids were really young, I used to get up at 5 in the morning, and then I'd work for a couple hours, and I'd go to work, do my job stuff, and then I'd come home and hang out with them, and then they'd go to bed at 7:30, and I'd work probably until 10:30 or 11. And that was my schedule for a long time. The kids get older now, 5 in the morning is my workout time. I do that early. I come home and hang out with them, and then in the evenings again, those are always good when they're no longer busy. But I tend to work it into little periods of time. I don't I work a lot less on weekends. I used to work on weekends. I almost never work on weekends. Like sometimes I might deal with my email or answer things, but I don't spend a lot of time doing those things, because like the family stuff is important to me and I wanna spend time doing that. But, I'll couch all that to say that, I told you time management's my superpower, so I do that well. Like I'm productive when I'm sitting there, like I'm just getting it done, I'm not dilly-dallying.
Right now, council meeting or council phone call, presidential line phone calls, it just overtakes our life. There's a lot of phone calls, a lot of meetings.
So those
lot
are
of
always,
committees.
those are always on the evening.
They're all in the evening.
Sometimes, every night there'll be something, but it's like,
I just,
not 8 to 9:30, but it's a finite period of time. Like I made this commitment to do this for 4 years, right? You're gonna do it for 4 years and then it's over and you move on and you do something else. So I don't think you want to say yes to too many things at the same time. I think you have to be aware of that. Like don't commit to things you can't get done.
more questions. Thank you very much. It was really fantastic to hear you. Well, it's to hear your life advice, which I think is very meaningful for everyone in this room, particularly the residents and fellows who are going to be going out to practice. A few gifts for you, right?
This is like one of the traditional gifts of UVA. No one could probably get the history of this as well as Rick or Jefferson. But you talked a lot about mentorship. This gift is built essentially out of mentorship. So George Wythe, who's essentially Jefferson's biggest mentor and signer of the Declaration of Independence, one of the first lawyers in America, bestowed on him 2 large chalices as a mentorship gift. And he actually put his own spin on those. So he had those melted down and commissioned Richmond silversmith to essentially form these 8 goblets that were more his style. And 4 of these still exist at Monticello today. This has become the traditional gift at UVA. I'm sure the faculty in the audience, probably everybody uses this to put their keys in when they get home. So essentially we all have one of these. So this is our traditional UVA gift. Every Morgan-McCue speaker has one.
Well, thanks, dude.
And then we like to run, so you're gonna mark at UVA Ortho everywhere you go. And then of course our standard, we have a plaque recognizing the lectureship and the Morgan-McCue. I can open. Yeah, the Morgan-McCue visiting professor in hand surgery as well. We have case presentations with hand fellows, hand team from 9 to 10:30 or so here in this room. But can I have the hand service, hand faculty up here and Dr. Morgan so we get a quick picture? You get the whole. Bobby.
Body hurt. You better